Today we're talking about the hormonal roller coaster of perimenopause and menopause, a journey that so many of us go through without a roadmap, without proper support, or even accurate labs. We're going to explore the real story behind estrogen, cortisol, and practical interventions that actually move the needle, like lifestyle medicine, where I always start, and when needed, bioidentical hormone therapy. Not everybody needs that, but a lot of us benefit from it, and every woman deserves counseling about it. Dr. Sara's 5 hormone commandments applied to perimenopause and menopause. So number 1, the main takeaway here is to start your journey with perimenopause and menopause with welcome to Treated, where science meets soul, where hormones finally get the respect they deserve. I'm Dr. Sara Szal, Harvard-educated, hormone literate, and fiercely committed to helping you stop suffering in silence. Quick sidebar, I always throw up a little in my mouth when I say that I went to Harvard. It's not because I'm not proud, it's just that it's nearly impossible to say it without sounding like a jerk who monograms their bed sheets. And that said, I did work my ass off to graduate from both Harvard Medical School and MIT, and I'm not going to pretend like it didn't happen. I'm from a place in Alaska where saying you went to Harvard means people immediately dismiss you. So you have to prove yourself even more. I try to strike this impossible balance between false modesty and sounding like a narcissist on LinkedIn. So let's just say I earned it, I respect it, and I mostly try not to lead with it unless someone needs a hormone whisperer with a PubMed addiction and a tolerance for complexity. End of sidebar. So today we're talking about the hormonal roller coaster of perimenopause and menopause, a journey that so many of us go through without a roadmap, without proper support, or even accurate labs. We're going to explore the real story behind estrogen, cortisol, and your eggs, with fresh research from neuroradiologist Lisa Mosconi and practical interventions that actually move the needle, like lifestyle medicine, where I always start, and when needed, bioidentical hormone therapy. Not everybody needs that, but a lot of us benefit from it, and every woman deserves counseling about it. So the spoiler alert here is that your hormones aren't broken. They're just begging for a better user manual. So today, let's write that user manual together. So part 1, what is going on in there, in the pelvis? Let's start with the basics. Your ovaries are biologically programmed to release about 400 to 500 eggs over your lifetime. And your ovaries are really your hormonal command center, producing estrogen, progesterone, and a whole symphony of signaling molecules that shape everything from your mood to your metabolism. In perimenopause, which can start as early as your late 30s or early 40s, your eggs become moody. Some cycles are strong, like they used to be. Some are weak. Some ghost you completely. And this makes your hormone levels, especially your progesterone and estrogen, bounce up and down like a kid that just drank some espresso. Now, enter some of the laboratory testing, like follicle-stimulating hormone. This is a hormone that's released in your brain that has a way of shouting at your ovaries. So it shouts louder once you start to run out of those ripe eggs. It's shouting, "Hello, is there anybody home?" That's what it's saying to your ovaries. So as FSH rises, estrogen starts to fluctuate wildly, and cortisol, your stress hormone, often rises in tandem. I've had a hysterectomy, a topic for another time, and so I use FSH to track menopause. Generally, when your level is higher than 25 or 30 or 35, depending on the study that you look at, it's considered menopause, chemical menopause, and that's the study criteria that we use. So I want to do a quick sidebar on this topic from related to Lisa Mosconi. I want to do a quick sidebar on Lisa Mosconi because she's a friend and a colleague, and I think her work is so important. Lisa Mosconi has some new research that I think is so relevant here. She focuses on perimenopause and menopause, and she really dials in the complex neuroendocrine dashboard and how that maps to your hormones, estrogen, cortisol, follicle stimulating hormone, as well as how you're feeling. So let me tell you about a couple of her studies. She does these neuroimaging studies at Cornell in New York, and she's shown that the menopause transition is associated with a dramatic decline in circulating estradiol. That's the most common estrogen of your reproductive years. And that leads to a change in the brain estrogen receptor density, especially in the networks in the brain that are involved in cognition and mood. So in the women who have higher brain estrogen receptor density, I know this is a little nerdy, bear with me, during and after menopause, those are the women who have worse memory performance and also increased mood and cognitive symptoms, regardless of what their serum level of estrogen is. So this is really important. So your blood level tells you one thing when you measure estrogen, but what's happening in your brain could be a different matter altogether. So when I read this, I thought, oh, I'm so screwed. I wonder if that's happening in my brain. So when we put this all together, what this suggests is that inside the brain, there's this adaptation to the loss of estrogen that may be related to the symptoms that we see in perimenopause and menopause. And there's more than 100 of them. So we hear a lot, especially in conventional medicine, about the most common symptoms: hot flashes, night sweats, mood swings, loss of libido. But there are 100+ symptoms. There's increased anxiety. There's difficulty with sleep, which is one of the early symptoms. There's vaginal dryness. There's painful sex. There's changes in terms of fibroids. There's increased inflammation, slowdown in metabolism, the musculoskeletal syndrome of menopause, which is where your joints are not quite as lubricated as they once were. Your fat mass increases, your muscle mass decreases, unless you're doing something about it. So 100+ symptoms. We'll link to some of these symptoms in the show notes. But I think the important thing here is that measuring your blood level of estrogen is a starting place, but it doesn't tell the full story. So a couple more things about Lisa Mosconi, because this is relevant to our user's manual for perimenopause and menopause. She has a recent paper looking at follicle-stimulating hormone levels, FSH. It's kind of the control hormone for your ovaries. So follicle-stimulating hormone, it's made in the pituitary. It talks to your ovaries about the release of estrogen. And we know that FSH levels rise significantly during perimenopause. This precedes the advent of menopause, which is when you go a full year without a period, or in women who've had a hysterectomy and you can no longer use that as a marker, FSH levels that climb above 25 or 30 or 35, that suggests that you're in menopause. So what Dr. Mosconi has found is that women who have very high FSH levels, that may be an important biomarker of ovarian aging, but also a potential mediator of the metabolic and the neuropsychiatric changes, including increased adiposity, more fat in the body, and also cognitive impairment. So this positions FSH as a possible target for future research into menopause-related brain and systemic health. So the main takeaway is FSH is important. Measure your estrogen, also measure your FSH. The other research that I want to highlight from her is on cortisol. So I've talked before about cortisol and how it's the biochemical boss of the hormones in your body. And Lisa has found something similar. She's found that cortisol as a marker of chronic stress is also implicated in the severity of perimenopausal and menopausal symptoms. Recent studies show that women who have higher perceived stress and elevated hair cortisol are associated with more severe symptoms of perimenopause and menopause, including hot flashes, night sweats, psychosocial symptoms like mood and wanting to get a divorce, physical symptoms, including aches and pains, frozen shoulder. There's a long list. And this indicates that the neuroendocrine stress response interacts with reproductive hormones, and this influences symptom burden. So put another way, when you have high cortisol during perimenopause, like I do, that may interfere with both estrogen signaling in the brain and also the FSH communication loops, especially in the hippocampus, the part of the brain that's responsible for memory and emotional regulation. This is a key memory hub, the hippocampus, and it's also what seems to be most dysregulated in people who develop Alzheimer's disease. So high cortisol may put the female brain at risk for shrinkage and potentially map to a greater risk of Alzheimer's disease, which we know is twice as common in women than men. So this can happen as early as your 40s. Alzheimer's disease is not something that occurs at 65 or older. It starts to happen in your body, in your brain, in your ovaries, decades before that diagnosis in your 60s or 70s or 80s. So we want to be thinking about these things in your 30s, in your 40s, in your 50s. As Lisa says, Alzheimer's disease is not a disease of old age. It is a disease of younger age and middle age. And women have double the risk of Alzheimer's disease compared to men. So we need to understand how our hormones map to this greater risk. So collectively, Dr. Lisa Mosconi's research underscores that the menopausal transition is this really dynamic neuroendocrine process. And the declining estrogen, the rising follicle-stimulating hormone, the altered stress hormone signaling with cortisol all contribute to brain aging, to cognitive symptoms, and overall health for midlife women. So that's my sidebar with Lisa Mosconi's work. So here's what I want you to take away. If you're starting to forget where you put your phone, where you put your keys, whether to pick up your kids from school, if you're forgetting names, you're feeling foggy, you're not sleeping, you're snapping at your dog, you're not losing your mind. You're most likely losing the hormonal rhythm of estrogen because anti-Mullerian hormone is declining as you run out of ripe eggs. Your mitochondria are starting to falter in both your eggs and your brain cells. It's not you, it's your mitochondria, and it's probably perimenopause and menopause. So let's talk about these hormonal phases and life stages. And I want to map the timeline so that you can figure out where you are in terms of the timeline. So for women, puberty is where all of this kicks off. It's when estrogen surges, periods start. That's when the brain rewires. This is increasingly early in girls. I started puberty at age 10. That's when I had my first menstrual period. How about you? So that's the first hormonal phase and life stage for women. The second is your cycling years. So this is when you have predictable-ish ovulation, you've got pretty high progesterone, you've got this monthly rhythm. For me, this was age 10 onward. Perimenopause is when progesterone drops first, and then estrogen becomes erratic. It can affect your sleep and your mood. And for me, this started at 35. So it's not too young to start to see these subtle symptoms, one of the 100 plus symptoms, as early as 35 to 40. Some women don't have much in the way of symptoms until 45 or 50 or 55. And the women who have the best lifestyle tend to have fewer symptoms. What Lisa Mosconi has shown is that 80% of women who have perimenopausal and menopausal symptoms have this slowdown in terms of the brain metabolism, where the brain is not able to use glucose as fuel the way it once did. And this is related to the mitochondria in the brain not working the way they once did. So that's perimenopause. It can last for 5, 10, 15, 20 years in my case. And then menopause is when you go an official 12 months without a period. Estrogen and progesterone hit all-time lows. And I just hit this point recently at age 57. I had a hysterectomy, so I had to confirm it with blood testing. And then postmenopause, which is the period of time after that official 12 months without a period or an FSH above 25 or 30, whatever your cutoff is, your body starts to adjust, but symptoms can actually still persist, especially if you're not getting the support that you need. I want to come back to the brain impact. It's something that Lisa Mosconi has really helped us understand better. And I feel like when it comes to hormone therapy, all women deserve counseling about hormone therapy and an evaluation for whether they're a good candidate. And to me, the most compelling reason to give hormone therapy is for brain health. So we know that estrogen modulates a lot of different brain chemicals, your serotonin, dopamine, brain-derived neurotrophic factor, which is like fertilizer for your brain. It also influences glucose metabolism. In fact, some of the researchers in this area say that estrogen is the most important regulator of your mitochondria. It's the most important regulator in the female body, full stop. When estrogen starts to drop, and that's, for most of us around 35 or 40 or 45, that's when you start to see brain fog and insulin resistance. It's when you start to see metabolism slow down. And this is why so many women gain weight. They feel mentally slower, like their processing speed is slower, and they lose resilience in their 40s and 50s. So we've got the work of Lisa Mosconi to show us that lower estrogen levels are associated with faltering mitochondria in the female brain. And in those of us that are candidates, we want to consider taking hormone therapy. That's where you got to see a clinician who's really wise and experienced who can help you and do the proper counseling. Now, I want to say a quick thing about men because often what I hear is, okay, women go through perimenopause and menopause, and men go through andropause, and isn't that equivalent? No, it's not equivalent. The decline in testosterone that we see in men is really gradual. It's not like this cliff that women go off of, which occurs depending on the status of your eggs and the mitochondria in your eggs, occurs at 35 or 40 or 45. So it's not a cliff drop in men. It's very gradual. It's a slow hormonal fade, not the roller coaster that women experience. Estrogen does matter for men. Men make estrogen via aromatase. Men make estrogen via aromatase, and it's key for men's bone density and also emotional regulation. And the myth of low T is often a cover story for other issues like high cortisol, poor sleep, and insulin resistance. And here I'm just going to wind down this call out to men because they already have a user manual, and women are the ones who need it written and discussed. So here's the next part of our talk about perimenopause and menopause. I want to talk about the common dysfunctions and root causes. So as you start to run out of ripe eggs, and also mitochondrial function starts to falter in your eggs and also in your brain, as well as other cells of the body, there's a hormone that declines called anti-Mullerian hormone, AMH. So you may have had an AMH checked if you struggled in the past with subfertility or fertility. AMH reflects your ovarian reserve, and it may help you estimate the timing of perimenopause and menopause. So the kind of dysfunctions that we want to be tracking include dysestrogenism, used to be called estrogen dominance. We want to look for low progesterone, which can affect sleep and anxiety and inflammation. We also want to consider other conditions like polycystic ovary syndrome and thyroid dysfunction, which is often underdiagnosed in perimenopause. In men, the things we get concerned about at midlife include low testosterone, high cortisol, and insulin resistance. And the root causes of both of these sets of dysfunctions include lifestyle-based factors like poor sleep, chronic stress, environmental toxins like endocrine disruptors, ultra-processed diets, sedentary lifestyle. And then there's your gut. In conventional medicine, perimenopause and menopause is seen as you're either in menopause or you're not. And it's all about your estrogen and progesterone. End of story. The truth is, the systems in which perimenopause and menopause are occurring are much more complex. You've got your immune system, your metabolic system, your amount of inflammatory tone that you have in the body. You have your gut. And so I want to talk about the gut for a moment because Your microbiome, the set of microbes that you have in your gut, as well as their DNA, they help to modulate your hormone levels. They help to detoxify your estrogen. It helps to balance your cortisol and regulate your blood sugar. So it's not just that you want to think about your ovaries and the production of estrogen and progesterone. We want to be thinking more broadly about the role of the gut, too. It is a hormone whisperer. In the type of lifestyle medicine that I practice, we think of the control system for your hormones in a very specific way. And here's how I think about it right now. I think of it as your HPA-T-GGG. What does that stand for? Your hormones are controlled by your hypothalamus, that's the H, and also your pituitary in your brain. The A stands for your adrenal glands, the endocrine glands above your kidneys. It's controlled by your thyroid, and then these 3 Gs, your gut, your genome, and your gonads. So ovaries in women, testes in men. HPA-TGG. Let's talk about labs. I really believe if you don't measure it, you can't modulate it. We check every hormone for a woman who's going through fertility or having difficulty getting pregnant. Why do we have the double standard that we don't check hormones when a woman's going through perimenopause or menopause? That needs to end. So here's the gold standard labs. We want to look for estrogen, in this case, estradiol, FSH, progesterone, testosterone, thyroid stimulating hormone, free T3, free T4, and fasting insulin. I also like to look at the saliva. I look at cortisol levels, and sometimes I do urine testing, looking for cortisol and estrogen metabolites. When do you want to test? For a woman who's still cycling, I like to test around day 19 to 21 of the cycle. For progesterone, I look around day 3 for FSH and estradiol. And for men, we look at early morning testosterone by 9 o'clock and also sex hormone binding globulin. So one of the concepts with laboratory testing is that normal is not necessarily optimal. We want to make sure that snapshots, which don't reflect the rhythm of your hormones, are used in context. We want to do a time series to see what's going on with your estrogen over time, see what's going on with your FSH over time, making sure that it doesn't climb so high that it puts you at that greater risk that Dr. Mosconi has identified with her work on the neuroimaging of women. So we want to track these trends over time. We want to look at the cortisol peaks in the morning and how it dips at night. We want to look at testosterone peaks, and we also want to look at estrogen pulses and waves, especially in perimenopause. There's also more advanced and optional testing that you can do, such as tracking your sleep and activity and stress, such as with a wearable. You can track your anti-Mullerian hormone for the reasons that we've just talked about. You can do continuous glucose monitoring, since women become more insulin resistant as we run low on estrogen. You want to track body composition, since we experience this metabolic downturn as a result of perimenopause and menopause. And we want to do advanced cardiometabolic testing, which we should cover in a future podcast. So this is not just what's happening with your total cholesterol and your LDL and your HDL and your triglycerides, but more advanced and specific testing. I like to do VO2 max testing in all of my patients. And I also do a coronary artery calcium score, sometimes a Clearly, in my patients that are at risk, and I do genomic testing. So as always, I recommend that you work with a knowledgeable clinician in the area of perimenopause and menopause, though they can be difficult to find. Fortunately, we've got a lot of femtech now that is making care for women in perimenopause and menopause much more accessible. So the final section that I want to cover is some of the interventions that work. I want to start first with lifestyle interventions because these should be at the foundation. So when it comes to lifestyle, I would say nutrition is the most important. So getting the right food that matches your needs, your lifestyle needs, your metabolic needs, the transition, regardless of where you are in perimenopause and menopause. And that may include having sufficient protein to maintain your muscle mass after 40. I'm a big fan of regular exercise resistance training. I think it should be 2/3 resistance training and heavy lifting together with 1/3 aerobic or cardio. I am a big fan of resistance training for the effect it has on testosterone. I also like zone 2 cardio to regulate cortisol. I'm a big fan of sleep. I feel like it's free hormone therapy. Deep sleep is where you make melatonin and growth hormone. You need that, especially through perimenopause and menopause. And then you also want to make sure that you've got blood sugar control. This is insurance with your estrogen and testosterone. In terms of nutrition, let me say a couple of things. Cruciferous vegetables are so important. Broccoli, arugula, Brussels sprouts. These are the champions of estrogen detoxification. If you need more information on that, read my book, The Hormone Reset Diet. You also need protein and healthy fats. They're hormonal building blocks. And you want to dial in your meal timing so that you eat with your rhythms and you don't carb load late at night. There's a lot of supplements and pharmaceuticals that can also be helpful. It's a bit beyond the scope of this particular podcast, but I like some of the cortisol tamers. Some of my patients find a benefit with rhodiola or phosphatidylserine or omega-3s, all of those shown in randomized trials to help with cortisol. I use and recommend creatine for many of my patients to optimize muscle mass and retaining their muscle mass as they age over 40. I'm a fan of bioidentical hormones. Estrogen, progesterone, DHEA, testosterone, but these need to be prescribed with nuance and laboratory testing. And I think it's important to point out that not every woman needs bioidentical hormones, but every woman deserves counseling for it. In men, I am a fan of testosterone therapy, but it has to be thoughtful. Not every man with low energy needs a needle. And then there's also the role of peptides and biologics, which we will cover another time. So not everyone is a candidate for hormone therapy. I want to make sure that that is loud and clear. You might have a recent diagnosis of breast cancer or blood clots, and that's where working with a clinician who's knowledgeable becomes so important. I'm also an advocate of what I call hormone therapy plus in perimenopause and menopause. It's not just slap on an estrogen patch and start taking progesterone pills at night. We need this more nuanced approach that puts lifestyle medicine first and contextualizes your life and your values and your why for why you want to live longer and better. The main takeaway here is to start your journey with perimenopause and menopause with lifestyle medicine, things like exercise, nutrition, sleep, and blood sugar control, and build from there. And I want to close with my Dr. Sara's 5 hormone commandments applied to perimenopause and menopause. So number 1, test, don't guess. Get blood tests done along with tracking your symptoms. Number 2, track your rhythms, not snapshots. Don't expect a blood test that you do once a year or once every 2 years to be sufficient to track where you are on the timeline through perimenopause and menopause. Number 3, tame your cortisol like it's your full-time job, because it is. Number 4, lift weights and lift your hormones. I didn't start lifting heavy until my 50s, and I swear by it. It makes you so powerful. It's such an important part of this hormone therapy plus approach. And then finally, number 5, your hormones are whispering. Listen before they start screaming. If today's episode hit a light bulb for you, if it helped you feel seen, please share it with a friend, with your sister, with your partner. I'm Dr. Sara Szal, and remember, your hormones are not broken. They're just begging for a better user manual.